Hello, everyone, and welcome to our webinar today. Thank you so much for joining us. Today, we will be presenting a webinar on strengthening oropharyngeal cancer screening in dental settings. This webinar is presented in collaboration with the National Center for Health in Public Housing, the National Network for Oral Health Access, and we also have a wonderful guest speaker from Regina Garcia Memorial Health Center. Before we continue, we have a few housekeeping items. Just as a reminder to everyone that all participants are muted upon entry. Please make sure you engage in the chat if you have any questions or any strategies or promising practices or any comments that you would like to share with us today regarding today's topic. Please also raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and the recording link will be sent to you all via email after today's session. Just a brief introduction about the speaker. So my name is Filipina Sandoval, and I am the TTA manager at National Center for Health in Public Housing. And with me, I have my colleague, Olajumoke Oladipo. She is our health communications and research analyst, and we'll both be moderating today's session. And we also have a wonderful guest speaker, Irene Hilton. She has served on the board of directors for 6 years at NNOHA. She also received her DDS degree from UCSF, her MPH from UC Berkeley, and is also a board certified in dental public health. She's also a member of the Best Practices Committee of the Association of State and Territorial Dental Directors and the Executive Committee of the ADA's Dental Quality Alliance. Thank you so much, Irene, for being with us. And we also have another guest speaker. Her name is Lisa Bozzetti. She is a dental director at the Regina Garcia Memorial Health Center. She has served as the dental director at VGMHC for 18 years, leading a significant program growth in innovation. And under her leadership, the dental program also expanded to 6 clinics and now includes school-based seal-in programs, integrated hygiene services, mobile outreach services, and dental therapists. She also has a diverse background across cultural, corporate, and community health settings, where she champions integrated care and oral health access, serving as president-elect of the National Network for Oral Health Access. So for today's objectives, we'll be focusing on describing the link between oral health, HPV, and oropharyngeal cancer. We will also be identifying screening and prevention strategies, including HPV vaccination. And then lastly, we will be discussing health center approaches to promoting HPV vaccination and cancer prevention. So over here, we have a brief background about the location of public housing primary care health centers and public housing developments. And according to the most recent 2024 UDS data, over 1,300 health centers serve to more than 32 million patients. 485 health centers also that were near to public housing served more than 6 million patients, and 107 of those health centers were public housing primary care grantees that provided services to more than 1 million patients. In terms of the public health center patient demographics, 2024 UDS data also stated that 76% of health center patients are below the federal poverty level. 58% are female, 26% are children, and 11% are elderly, and as well as 18.9% are uninsured patients. So according to the U.S. Department of Housing and Urban Development, picture of subsidized households, public housing here we have some information about the public housing residents demographics. And we can see that 1.6 million residents live in public housing. There are also 2 persons per household, with 32% female-headed households with children. And 35% are children, 40% are elderly, 23% are disabled amongst all persons in households, and 90% are within the very low income bracket. Well, this all of this information is just important to notice given the need that these patients may be having in terms of having the appropriate oral care and prevention strategies for them to be seen at their health centers near where they live at. So now I will pass it on to Irene to get us started with the oral and oropharyngeal cancer presentations.
Thank you, Fide. And good morning, good afternoon, everyone, depending on where you're at. So I'm Irene Hilton. I'm going to be talking about oral and oropharyngeal cancer, giving some of the data about that. So first, just 2 slides. I'm representing NOAA, which is a national nonprofit that was founded 35 years ago. It's our anniversary year by 9 FQHC dental directors who identified a need for peer-to-peer networking. And we've grown from those 9 people to now we have over 5,000 dentists, dental team members, and supporters as our membership. We receive funding from HRSA. We are the National Training and Technical Assistance Partner for all things oral health. These are some of our HRSA-funded technical assistance activities. If you want more information about managing and running your health center dental program, visit our website, noaa.org. So what is oral and oropharyngeal cancer? So it's a cancers that affect either the mouth or the related structures all the way down to the oropharynx. So just before or just after you start hitting like the esophagus, up to the esophagus. So in the mouth, the most common sites are the tongue, which is here you can see on the upper left, the floor of the mouth, which is what you can see on the lower left, the gums, which is what's surrounding the teeth, which you can see on the right there, and then less likely to occur on the insides of the cheeks, the top of the roof of your mouth, or the palate, or on your lips. And then in the middle part of the throat, which is what we call the oropharynx, which is past, we'll say where the base of the tongue is, and you know how when you have a cold, sometimes the back of your throat gets all red and inflamed. So that would be the tonsils and the base of the tongue. So those are when we say oropharyngeal cancer, those are the areas of the body that we're referring to. So here are some facts about oral cancer, and these are estimates from cancer.org, that it's they're estimating that for this year, you're going to have about 60,000 new cases and about 13,000 people will die from oral and oropharyngeal cancer. The 5-year survival rate is actually a little bit site dependent. So if it's on the tongue, it's going to be about 71% 5-year survival rate. If it's in the oropharynx, it's actually everything drops from there. Oropharynx is going to be about 57%, and the floor of the mouth, it's 52%. The average age at the diagnosis for all types of cancer all types of oral cancer is 64. However, and we'll talk a little bit more, this will be clear later, 1 in 5 cases involve individuals under 55 because the age range is starting to get lower. And the lifetime risk, so it's men are much more likely to get oral cancer than women, as you can see by the 1 in 59 versus 1 in 139. So here are some data from the National Cancer Institutes to show, and this is the oral cancer rates by sex and by race ethnicity. And here you can see, like I said, men are much more likely to get oral cancer than women. And here you can actually see some disparities where non-Hispanic white men and Alaska Indian, Alaska Native men are much more likely to get oral cancer than other race ethnicities. So there's been over the last, we say 25 years, a changing epidemiological trends in oral cancer. When I went to dental school, which was more than 25 years ago, the paradigm, the standard paradigm, the old style, was that an individual that got oral cancer was more likely to be a man, but they were more likely to be over 50, to be a smoker and or smoker and alcohol consumption, and the oral cancer was related to tobacco as the primary cause, and tobacco containing carcinogens that would damage your DNA and then cause genetic mutations in the mouth. And again, the most common sites would be the tongue, and with a later stage of diagnosis. Now what we're seeing is a shift to the new paradigm, which is oral cancer in individuals, starting to see increases under 50 who are non-smokers. And now we're looking at an HPV 16 related cancer, and which biological mechanism there is that the virus disrupts an individual's own tumor suppressor proteins, thus allowing mutations to occur and cancer to develop. And the most common site for HPV related cancer is the oropharynx, but we also tend to have an earlier stage diagnosis. So here you can see, and I just want, this is change, and this is in terms of oral cancer death rates. And so what you want to see is how there's been this change, an increase in, if you look at the top red lines, you can see for males that there's been increase, and that's why it's 2.1%, because the increases, as opposed to, for example, like lung cancer rates are actually going down a little bit, but they're being replaced, by oral cavity and pharynx cancer for both male and female. And this is like almost 100% related to the emergence of HPV cancer, HPV related cancers, as opposed to tobacco related cancers. So you can see, if you look at lung and bronchial cancer, how it's actually dropping, right? And if you think about smoking related cancers. So and again, because of that, because smoking rates have decreased across the United States, over the last 30 years, and so the incidence of oral cancer and what we would used to call the traditional sites for smoking related cancers, which is the tongue and the floor of the mouth, have decreased. And again, here's a lesion on the tongue, so you have to pull the tongue out in order to be able to see this on the side. And here's just some data looking at percentage of adult smokers. So again, if you're in one of the states that's on the right, then you still have to think about smoking related cancer as a primary cause of oral cancer, as well as other types of cancers. If you're on the left, these are the states with the lowest percentages of smokers, adult smokers. There's more than one way to get tobacco-related oral cancers. Traditional cigarette, pipe, cigar is just one way in which tobacco can be delivered. We also have smokeless tobacco in the middle, and when you do have smokeless tobacco-related cancer, the lesions is going to be wherever the person puts the smokeless tobacco. So it's usually going to be like a little pouch, between the gum and the cheek, whether it's on the top or the bottom. Hookah is also another way to get tobacco-related products, and again, have the same potential mutations. And then e-cigarettes, even though there hasn't been any studies or data showing that e-cigarettes, because of their relatively new, emergence, is a direct cause of cancer, there has been plenty of research showing that e-cigarette is a pathway to traditional tobacco consumption, which is then going to result in potential oral cancer incidence. So again, we talk about smokeless tobacco. Here's on the cheek is where it would be. Again, we've got about 4% of US adults that use smokeless tobacco, but actually have a slightly higher percentage of high school students that use smokeless tobacco. So this is, again, something to ask in our medical histories, especially in teenagers. And here you can see the hookah. And again, it's equivalent to smoking a bunch of more cigarettes because of the way the nicotine is delivered. So again, something else to ask about in our medical histories. And as we said, for the cigarettes, they have a lot of, like I said, all these side effects to begin with. And again, it's a gateway to conventional cigarette smoking for youth. So our action steps as clinicians for tobacco-related cancer is that individuals that are most at risk tend to be uninsured because again, they're adults and have less dental access. And so early youth prevention, especially again, is related to e-cigarettes and smokeless tobacco, is one of the things, identification, and then getting people into prevention programs. So again, screening in the medical and dental setting for use of tobacco or tobacco-related products, and then a referral to either the behavioral health in the health center or a state quit line or other educational intervention. So here's again how to do an oral cancer screening for both any medical or dental or actually anybody that's on. You want to first it's the tongue, and you just ask people to stick their tongue out. You just grab it with a 2x2. Don't pull it, don't pull it out, but you can grab it, where the patient feels comfortable. Then you flick it to one side, you flick it to the other to check the size of the tongue. And then you can ask the patient, again, without pulling on it, to say, ah, and that will completely drop their tongue down. You'll be able to visualize the entire oropharynx. Then you let go of the tongue, and then you just lift the lip to look up at the gums, and then pull the cheeks out so you can see the cheeks. Now for HPV, the action steps for HPV-related cancer is a focus on early cancer prevention, immunization, and early detection of lesions. So Lisa's going to talk more about the program that they have set up in her health center for HPV prevention. And again, the screening in the medical and dental setting, both for appropriate immunization status or actual early detection of lesions. And then referral for immunization administration in the medical or dental setting if they're not up, like I said, on their immunizations. The oral cancer, the oropharyngeal HPV related is actually, I'm going to say, kind of interesting because it's very hard to diagnose for clinicians, because if you look at these little lesions where the arrows are, I mean, it almost looks like everybody's sore throat does after, when you have a cold, right? And it swells up and you've got, little red blobs in there. And so what you're looking for is, the 2-week rule, right? Like it's there for months, the same lesion. And the most common diagnostic is actually a painless lump in the neck that patients themselves are identifying, or the primary care provider or dentist, because of the lymph nodes. So it's a little bit less obvious to diagnose than, we'll say, traditional tobacco-related oral cancer. But really is that just the whole oral and oropharyngeal cancer, whether it's smoking related or HPV related, is a really great opportunity to engage in whole person care for both medical and primary care and the dental side, because we can both do and conduct oral cancer screenings and screenings for immunizations, and then preventive immunization, and then refer across disciplines to get our patients the care that they need, and as well as Lisa's going to talk about at her health center, where the dental themselves can administer immunizations. So here are some resources for oral and oropharyngeal cancer with some educational materials for patients. And then I'm going to turn it over. Let me stop my share and turn it over to my friend and colleague, Dr. Lisa Bazzetti.
Thank you, Irene. Appreciate it. I'm going to be diving a bit more into HPV specifically here as I get my screen set up here to share. All right. So I'm going to be speaking a little bit more specifically about HPV and how our dental teams have been able to be a big part of educating patients about the cancer risks associated with, particular oropharyngeal cancer risks associated with HPV, and how we can offer an amazing preventive tool, the HPV vaccine. So, before I kind of dive into all those details, I want to share a little bit about my health center. Again, I've served as dental director for Virginia Garcia Memorial Health Center for 18 years. We are located in Oregon. We are one of the larger health centers in Oregon, and we serve two counties that are just west and southwest of Portland, Oregon. We have a really interesting mix of urban and rural communities that we serve. And our namesake is little Virginia Garcia, who you see on the left-hand side of the screen here. And her story was that back in 1975, she came with her agricultural worker parents to Oregon. And somewhere along the line, she developed a simple foot infection. And due to cultural and linguistic barriers to care, she was not able to get the care that she needed for a completely preventable infection. And unfortunately, she passed away from this. And the community came rallied together very, very quickly and thereafter. And just a few short weeks afterwards, the very, very first Virginia Garcia Memorial Health Center clinic opened in a three-car garage in Cornelius. And those are some of the pictures that you see at the top of the screen here. 50 years later, we've grown pretty substantially and serve more than 52,000 patients in those two counties. We have primary care clinics, pharmacies, behavioral health services. We also have dental clinics. We have six with the seventh on the way. We have school-based health centers that also have dental care incorporated into them and a school-based sealant program, a reproductive healthcare clinic, multiple mobile clinics with some additional mobile clinics, some sprinter vans that are coming into our fleet in just a few short weeks, and a centralized administration building. We serve one in every 14 residents in the two counties that we serve. So to start the conversation around HPV, I really want to start with a statistic that Irene spoke to, and that is it's a really stark statistic that of all of the oropharyngeal cancers, 70% of them are HPV positive. And I really like this slide because it shows, what it shows the impact of HPV infection on head and neck cancers in general. And I think this is really the reason why we as dental professionals need to care about this. And this is why the dental team is an ideal opportunity to educate our patients, not only about prevention, but about screening for oropharyngeal cancers as well. So let's just kind of get to some basics. I'm going to do just a very basic overview of what HPV is. Human papillomavirus is the most common sexually transmitted infection in the US. Nearly every sexually active person has an HPV infection at some point in their lifetime. There are 79 million Americans that are currently infected, 14 million new cases every year. And HPV infection is most common for people in their teens and early 20s. Most people actually never know that they are infected. And why discuss HPV at dental visits? If it's not already obvious from that statistic about HPV positive infections, then our cases of oropharyngeal cancer are rising. Irene did a really great job explaining that in the previous slide, so I'm not going to stop too much on that. But I think it really provides dentists as an opportunity to provide primary HPV-related oropharyngeal cancer screening. We already do oral cancer screenings. That's a normal part of any dental exam. Yet many dentists do not provide additional HPV-related prevention. We could be doing counseling. We could be doing referrals for vaccination. I'm going to concentrate a lot on the counseling piece because many states don't offer the opportunity for dentists to be able to administer vaccines. While that is something that we do. I do really want to concentrate on just the information sharing that that dental teams can be vital in providing. I want us to stop and think about this for a few minutes. In the age range of like 9 to 12, which is the age range that we start recommending HPV vaccines for young adolescents, this is this period of time where a lot of these kiddos are not seeing a doctor regularly. But a lot of these kids are actually seeing a dentist either regularly or sporadically. So, given the number of young adolescents that we see and unvaccinated kiddos at that in a given year, it's an excellent entry point for us to have conversations about HPV vaccine education and potentially delivery if possible as well. So I want to be honest about that we had some really amazing fortuitous events that occurred to be able to make all of this possible in our health center. The first of which was Oregon House Bill 220. This was a bill that allowed dentists who complete a Board of Dentistry approved curriculum to administer all vaccines in Oregon to all ages. And you read this right. This was actually passed in 2019. This was incredible timing on our part. Less than a year later, we were in the throes of the pandemic, and as they were looking at as they were looking at a potential for a vaccine, we knew that we didn't have to have an emergency order. We knew that we could rely on the fact that our our dental school in town, our Oregon Health Sciences University, actually had a course that our dentists could take to become vaccinators. And so this was particularly helpful during when the vaccine became available. We decided to train all of our dentists to become vaccinators. So it really started in the COVID days where all of our dentists were participating in the delivery of vaccines. After that, we started to consult with our medical teams and we wanted to see what vaccines perhaps could be helpful for our dental team to provide. And we had a lot of discussions. We landed on flu and COVID for sure. Particularly back in those days, we were really trying to have, large COVID clinics or COVID vaccination clinics, large flu vaccination clinics, and it was particularly helpful to include the dental teams. There was a little bit of a conversation about Tdap, which was a vaccine that was often missed for young children, but that was a complicated forecasting schedule. What we landed on was HPV. And the reason we landed on HPV was really due to the implication of preventing oropharyngeal cancers as a prime motivator. Also, adolescents are, it's a complicated age to get both of the vaccines that are required for HPV. It's hard to get adolescents to come in, just really period. So we ended up concentrating on HPV as a potential entry point for our dental team to administer some vaccines. And also during this period of time, in 2021, there was an Oregon HPV dental task force that was assembled. It convened dental professionals from both the public and the private sector, and we met with two primary goals. One was to educate us on HPV and HPV prevention through the vaccine. And the other was to collaboratively create an educational toolkit that could be shared. I'm going to be sharing that toolkit a little bit later on in the presentation here as well. And we spent months learning about HPV from some really amazing professionals and putting together a toolkit that can be used even outside of Oregon. So I was fortunate to be a member of that task force, and of course that made a big difference in my work around this as well. So I do also want to admit that our dental teams were doing a lot already to support overall health. This really wasn't kind of an accident. prior to even participating in the oral health task force, we operate in a shared electronic record. We are an Epic, which really makes all this very, very possible. But our teams were already querying our state vaccine registry. We were reconciling vaccines and we were recommending overdue vaccines to our patients as just part of our normal process. We were advising patients and scheduling vaccines on the medical side. We were also dipping our toe in the water of looking at overdue A1Cs. Now we also administer A1Cs and result them. But at this time, we were already doing a lot of these things. So it made sense to be able to take it to the next step and be able to deliver vaccines as well. So HPV vaccines really presented an amazing opportunity for the dental team. Again, the forecasting is relatively simple for the HPV vaccine. For young adults, the recommended starting age is 9 years of age. And if the vaccine is begun, then it requires 2 doses if completed before age 15. For anybody who's catching up later on, it's 3 doses. It's very, very simple. The spacing is 6 months between doses, between 6 and 12 months between doses. Really, like compared to a lot of other vaccines, this was a very, very simple one for us to work on. Our teams, we chose to predominantly reach out to folks who were 26 and under, and I'm going to be honest, it was a little bit for insurance reasons. It was easier to code and easier to handle. But I do want to be clear that there are opportunities for folks older than that to get the vaccine, and it is recommended to have some shared decision making with a medical provider for getting vaccines at that age range. So, our rollout of this HPV vaccine awareness campaign and vaccine education campaign really fell into 3 parts. And I'm going to discuss in a little bit more detail, particularly this first part, which is the patient and staff education. In order to be able to do this work, we obviously had to do a lot to educate our staff on what HPV was, why we should be talking about it with our dental patients, and really helping them to feel comfortable having those conversations. We did all dental staff presentations. We did provider meetings. We had a standing topic at our provider meetings for actually well over 2 years. We did a very, very specific informational session just for dental assistants. We distributed patient-facing materials, provider-facing materials. We had just a lot of standing topics about this for about 2 years' time. I could do a whole presentation just on workflow and billing and coding, but suffice it to say, we had to kind of play around with whether or not to use the CDT code or the CPT code, who to bill out under. We ended up landing on billing out under a medical provider that is in the clinic. That ended up being just an easier fix for us, and we were doing this in our co-located sites. And then the last piece was really around administering HPV vaccines. We didn't do that until a full year, year and a half after we did the educational campaign because we knew that that was going to take a lot of heavy lifting to get there. And I really can't stress enough about the education of our dental teams. I'll talk about this in my wrap up, but the providers were really an easy sell for having these discussions with our patients. Our dental assistants were a lot tougher sell. They couldn't quite understand why we needed to have these conversations. And one of the recommendations that I'd like to make is we had our one of our DA leaders, our DA trainer, take some time to learn about HPV and then create a presentation to the dental assistants at one of their group meetings. We vetted all the information, of course, but it gave an opportunity for them to get it from one of their own leaders, and that started to kind of turn the tide for us. Um, I can't stress enough that having these conversations is challenging. It's hard to figure out a place to have a conversation about HPV and the HPV vaccine. And even though our providers were really on board for the conversations, they also struggled with how to start the conversation. We use the existing materials that were created from that dental task force that I just shared about, and that helped us to not only educate ourselves but also educate our patients with those patient education materials. And of course, lastly, we would recommend a vaccine either in the primary care clinic or in the dental clinic if we could offer it. I want to share one of the brochures that came out of the Oregon HPV task force, and that is this trifold brochure. There's a link here for you to be able to access the materials yourself. I want to share that you can brand it yourself. You can tell that the Knight Cancer Institute that also funded some of this work for us, they have their logo on this, and we put our logo to the left there, but that space is blank if you want to be able to use these materials yourself. There's also provider-facing materials, and this was important to have, just some key messaging for providers. The This is a little card, and it has on one side the dental provider checklist, just to ensure that they remember to check the chart to see if the vaccine is due, make the recommendations, answer any questions that they are able to answer, give the patients a handout, and then document in the chart note. But also on the flip side, it gives some of our key messages for HPV vaccination, which I'm just going to read them here. HPV vaccine prevents against 6 types of cancer. 2 doses are recommended between ages of 9 and 12, and most importantly, it's for boys and girls. HPV vaccine is safe and it works. So to kind of dig a little bit more into messaging that we had for our patients, we really talked a lot about like, hey, did you know that there's a vaccine that actually can help to prevent some cancer and head and neck cancer? So it's really relevant to the work that we do. Again, the 70% of oropharyngeal head and neck cancers are HPV positive was a big part of our messaging internally with our dental team. And the dental team can really be seen as a great extension of the team recommending the vaccine and administering the vaccine when feasible. One thing I would point out here is that having similar messaging to your medical teams is really critical. We did a lot of work with contacting our medical teams and ensuring that we have similar kind of advertising, if you'd say so. We wanted to make sure that we were giving the same information to our patients from both the dental teams and the medical teams. Here's an example of one of the ad campaigns from the CDC. So just to share that there are a lot of different options of materials that are out there. The key messages here were really around, again, cancer prevention. I'll tell you that dental folks don't like to talk about sexually transmitted infections, and this was a way to kind of get around that, even though it obviously is. Talking about cancer prevention was a much more comfortable topic for our dental teams. Some of the things that we came up with were that you review vaccine history much like you do a health history. You can also provide an entry point through when you're doing your oral cancer screening. That can also be an opportunity to bring up the HPV vaccine if it's appropriate at that time. You can add sections to your patient questionnaire about HPV vaccine history and recommend vaccines much like you would recommend dental needs. We included in the after visit summaries. We automated it so that overdue vaccines automatically go into the after visit summary. So there's a lot that the dental team can do here. And we really want to reinforce HPV vaccination as the norm, just like parents, choose to vaccinate their child as infants. Again, just consistency of messaging is really key. So, I'd recommend if you're doing this work with your primary care partners, check in with them and make sure that you're all on the same page. I do want to stress that there are some complexities to this, and if there is a question that our team members got about the HPV vaccine that they just really didn't know, it's okay. We as dentists are not experts on HPV, and we are not going to have all of the answers. So it is absolutely appropriate to defer to a patient's pediatrician or PCP in that case. If ever there's a question about dosage, the number of dosages, if ever there's like something that's confusing or complicated about a particular case, I tried to really emphasize that we don't need to know the answers. It is okay to refer the patient back to their PCP. So, really, really key point that we have partners in this. And I can't deny that there are a lot of advantages for us doing this in an FQHC setting. Our dentists and hygienists, they, already administered COVID vaccines and flu vaccines alongside our medical colleagues. We talked about that earlier. It's really an accepted part of our workflows. We value integration so much that, we are in an integrated record. We already were querying, our state vaccine registries. We were already reconciling vaccines. So this was kind of a natural, normal extension of some of the work that we were already doing. And we decided to pilot the administration of HPV vaccines in our dental clinics that were co-located with medical. The reason for this was very, very intentional. We didn't want to invest in vaccine refrigerators and all of the maintenance that goes along with them, and in case this like kind of didn't work. So what we decided to do was we share the supply with medical. We don't do a large volume. I'm going to let you know I would say the volume is on the lower end of things, and I'm not even sure that we will continue to administer vaccines. But at this point, it has been successful by being able to utilize primary care's supply. All of the supply is monitored through our electronic health record. Again, since it's shared, it's not something that we have to do extra work around. And even though we can order vaccines on our own as dentists in Oregon, we have chosen to bill through physicians on site for simplicity reasons. There are a lot of lessons learned about this work. I mentioned some of them in passing here, but just to kind of summarize everything on these last few slides, our providers were much more receptive to learning about HPV and learning to message patients, but they also really, really struggled with how to start a conversation about HPV. It's challenging when you're used to doing things a certain way and the conversation has not included HPV before. Our DAs needed a little bit more time to warm to the idea. And I can't stress enough that it was critical for us to have the DA leader learn on their own about HPV and make a presentation to their own peers about HPV. Um, Parents and patients seem to anecdotally be more open to receiving dose 2 or 3 from a dentist. That's our experience. Again, I just recently looked through all the doses that we have given, and we have actually only given second or third doses. I am going to admit, when we started this work, I thought we would be giving a lot of first doses because I thought we would be starting the series. But it turns out that when parents or families have those conversations with their pediatrician or their family doctor, they are much more likely to come back and get that second dose from us. And then just to kind of wrap up those concerns, anytime there was a concern about answering a question, we always just would defer back to the primary care or primary care provider or pediatrician. So hopefully the key takeaways that you'll get from all of this are that dental teams should be a natural part of messaging our parents and patients about HPV. The key message for us, at least, has been around cancer prevention, and dental teams can have a big role in helping decrease HPV-related cancer rates through vaccination as well. I've included just one slide with some resources and toolkits. Again, that Oregon HPV toolkit that I shared earlier is available here in addition to some CDC resources and some great resources from the ADA and the American Academy of Pediatrics. So thank you. I'm going to forward to the last slide with contact information from NOAA as well. And I think we are ready for some questions, Fide.
Yeah, awesome. Thank you so much. Let me share my screen real quick. That was a wonderful presentation. Thank you so much. We learned a lot about the background information and oral cancer and smoking and all those triggers. And then at the same time, it was very helpful to learn about all the wonderful work that the Virginia Memorial Health Center is doing. But right now, we'd like to open it up for the audience and see if there are any questions that you would like to ask. Just as a reminder that you can also raise your hand if you would like your line to be unmuted. We will unmute your line if you would like to also ask your question verbally. See. So we'll give a few minutes to the audience, see if we have any questions.
Well, we'll wait for some questions from the audience. I would like to ask a question to Lisa. And Lisa, do you see more resistance when you offer the vaccine to boys, or is the same resistance if you offer the vaccine to boys and girls?
We haven't really seen much of a difference, honestly. I think when we first were going down this path, we were assuming that perhaps like parents of girls might be more inclined to accept, and a lot of the initial advertisements were with girls, but I can say, at least in my own experience, I've actually vaccinated a few boys who had already started the series, and yeah, does not appear to be a difference kind of between the sexes as we can tell, at least.
Excellent. Thank you, Lisa. Another question, Lisa. One of the concerns at least in the past, was that some children or boys or adolescents were reporting fainting after receiving the vaccine. Have you seen any case or anything related?
We haven't, but I had also heard about that. I have heard from my medical colleagues that it's one of the most painful vaccines to receive. So my assumption is that that is why. So that is something that we have talked to our teams about, is being aware of the fact that this can be really, really painful, and to be aware of it. Again, I think we're lucky because the ones that we have done have all been second or third doses. So, they've had the experience of at least having a previous dose before.
Okay.
All right. So we have a few questions that have just come in the chat. The first question says, have you seen an increase in vaccine declination with EHS removing recommendations for specific vaccines?
I would say we have more of an uphill battle than it's hard to say specifically, but we actually have been doing a lot better with our HPV vaccine rates. And I think partly it's because of the work that we're doing in dental, and also medical's been also doing quite a bit of work on messaging for HPV in particular. So even though, kind of the political environment might be um, might be different at this time. We have not been seeing that, at least around HPV vaccination rates.
Okay. Well, thank you. We have another question. Do you have a one-pager educational material about OC for patients in your resources
About
or cancer?
oral cancer, I we just have on HPV, at least the information that I shared. I'm not sure if I have a one pager on oral cancer in general. I know there's some great resources around, like, like 6-step screenings for oral cancer. I know that I know that there are some great resources around. I'm guessing that we might have some at NOAA on our NOAA website, Irene. I can't say for sure.
You, in the slide where I had resources, the first two um, are downloadable. I mean, it's actually really interesting that it seems like there's less and less downloadable resources now, as opposed to like links, where you just
Mm.
link people to websites that have like the information. But like I said, if you go to the slide that's got the resources on, or when you get this presentation or you download it, the first two um, have links, or are resources that you can then download and print out, which is the ones from HRSA and the ones from the Mouth Cancer Foundation. So there is stuff available online, but like I said, a lot of stuff seems to be switching over to less physical reading material, to links and QR codes that you can just send to people's phones.
Awesome. Thank you so much. And I believe Jamoke, she just pasted some of those links that you provided. So they're in the chat if you would like to have direct access. We also have another question. Are vaccines done on a separate visit than the dental visit? Or do you do vaccines during the dental visit? That's a great question.
That is a great question. We do try to do them at the same visit. So I always say that, like, there's some dental visits that are really quick and easy and would be a perfect opportunity to be able to administer a vaccine. Other visits, probably not so much, and then it's absolutely appropriate to schedule the patient as they're walking out the door. So, yeah, the if possible, we're not scheduling a separate appointment to administer a vaccine.
Great.
I could maybe clarify as well. One of the things that we do as well is that our DAs are able to actually go and pick up the vaccine from the fridge. They know how to prepare the tray. They know how to bring everything to us. So there's not a lot of preparation that's needed to be able to actually administer the vaccine. And we don't actually puncture the vaccine vial until we know that we're administering it. So we would be able to, like, put the vaccine back if somebody were to change their mind.
Yeah. Awesome.
We have
And
one
then
more question in the Q&A.
mhm.
Someone asked, do you know if the patient is already known to be sexually active, and should there be testing prior to vaccination?
We don't generally know that information as dental teams. I mean, there may be information in their chart, but that's not something that we necessarily are asking about. My understanding of HPV vaccines is that, I mean, it's really ideal to catch them at very, very young before they are sexually active.
I would recommend that a site is immunize.org, and there is a section on that website is Ask the Experts. That section has responses from the Advisory Committee on Immunization Practices, the CDC's ACIP, and they do recommend the vaccine, even if there is a history of whether or not the child, or the adolescent is sexually active. Is recommended.
Thank you, Dr. Leon.
Mhm.
Yep. All right. Well, I guess
There is one more question.
okay.
Is just wondering how that will affect our needle fearing patients getting shot up in the arm and then the mouth. I think that was more
Yeah.
like a joke than a
Yeah,
question, but
like a follow-up to the question about when
It-
vaccines are administered. But yeah.
we do have
Yeah.
one more though.
Oh, I can speak to that. Typically, I mean, we're getting the dental work done first, and again, if there's time, we can administer the vaccine at the end of the visit. So typically, they're spaced out. The vaccine would occur at the end of the visit.
We have two more questions. Someone asked, is there a maximum age recommendation for HPV vaccines? And Chung also mentioned, what is the age of consent for HPV vaccination in Oregon? And do you have a separate consent they have to fill out for a dentist to be able to administer?
No, there's so I can speak to the age of consent in Oregon is 15. If we are doing this on children under the age of 15, we do need parental consent. It's verbal consent. We do not have a form,
And there is,
and that is typical for vaccines in general.
and I can speak to the age recommendations. So there has been some recent research that it's even effective in adults. It's not I'd say like recommended, like it's less effective. Like I think it's recommended up to 26 if you haven't gotten it, but it has shown that there is some efficacy to, again, preventing the development of cervical or other cancers up in 45 is actually like it's acceptable to get it done up to age 45. And it may be even, I think that's about the range, because I remember reading, like I said, that the research it's increasing, right? Like they thought it was just for prevention, but like that the preventive window actually extends even in older individuals. Now, whether it's covered by insurance is always another question. But in terms of clinical efficacy, I don't know, Jose, if you have what your thoughts are on that.
I'm sorry, Irina. I got distracted. I'm sorry. What was the question?
About the emerging research that HPV vaccination up to age 45?
The recommendation from the Centers for Disease Control is that there has to be some communication, between the clinician and the patient. And if there is, if this is a high-risk patient, for instance, then the vaccine is still, recommended. But there has to be an off-label use of the vaccine because there is no research, after age 26. But if someone wants to receive the vaccine and there is communication with the doctor, the vaccine can be given to patients, after the recommended age.
Mm-hmm.
All right. Well, I don't see any other questions. Jamoke, do we have anything else? Any other
No, that
questions?
was it.
Okay. All right. So we're just gonna go over our closing remarks. Just a reminder to please complete our post-evaluation survey. Let us know how we did. And again, this webinar is supported by the HRSA and Services Administration. And here is our contact information as well, and everything is provided in the slides. And thank you everybody for joining us today. And it was a pleasure hearing from you, Lisa, and also from you, Irene. Thank you so much for a wonderful presentation. And that is it for today. Have a wonderful day. Thanks.
Bye,
Thank you so
everyone.
much.
Thank you.